Thanks for joining us. I'm your host, Raquel Faria. I'm a doctor in internal medicine at the Centro Hospitalar Universitário de Santo António, no Porto. Today, I'm joined by Professors Eloisa Bonfa and Murray Urowitz from the Lupus Academy Steering Committee. Eloisa and Murray, welcome, and thank you so much for joining us today.
Thank you, Raquel. Great to be here.
And today we are going to discuss a couple of cases of neuropsychiatric manifestations in SLE patients. And here, to your experience, opinion, how do you approach these situations? It's so helpful to listen to experts. This is one of the manifestations of SLE that has most unmet needs, both for diagnosis, attribution, treatment options. People might say, oh, these patients have neurolupus. And at this time of the state of the heart, it gives me chills. And because NP manifestations in lupus are classified, there are at least 19 different syndromes that might have completely different physiopathological mechanisms and, of course, different treatments. When a patient with neuropsychiatric manifestation, it is crucial to approach the manifestation as if the patient didn't have lupus, which is a little bit different from other involvements. And then you need to do the job for the attribution of this manifestation. And we'll have the opportunity to discuss this later. Then decide what is the most appropriate treatment. This is particularly challenging since none of the neuropsychiatric syndromes in SLE are specific to SLE. And some of the manifestations are so common in the general population. There are no specific patterns on the neuroimaging. There are no specific CSF or serological biomarkers. So the gold standard is still for the neuropsychiatric SLE diagnosis, the expert's opinion. That's why it's so important to discuss this with you. Let's hear Murray's and Eloisa's opinion on some clinical vignettes. So I hope you are ready. Let's dive on the first case. The first case is a 42-year-old woman who was diagnosed with lupus. It was based on discoid lupus lesions, photosensitivity, arthritis, oral losses, positive anti-nuclear antibodies, anti-dsDNA, anti-Ra antibodies. So full-blown lupus. Other extractable nuclear antibodies and antiphospholipid antibodies were negative at the diagnosis, and she was treated with low steroids, hydroxychloroquine and methotrexate. The relevant past history was hypothyroidism due to autoimmune thyroiditis. It's really common in lupus to have a thyroid autoimmune disease. She was doing supplementation with levothyroxine, and she had a first trimester spontaneous abortion and another normal pregnancy 11 years before this episode that we are going to count now. 9 months after the SLE diagnosis, she developed a class 4 lupus nephritis. Methotrexate that she was doing for the arthritis was stopped, and induction lupus nephritis treatment was started with 3 days pulse of 1 gram methylprednisolone and cyclophosphamide in the Urolupus protocol, and 30 milligrams of prednisolone and 200 milligrams of hydroxychloroquine. 1 week after starting the first pulse of cyclophosphamide, the patient presented with numbness and paresthesia in the left arm and hand, and speech difficulties, and she was admitted at the emergency room. She had dysarthria, paresis of the left upper limb. They were confirmed on the physical examination, and the brain scan confirmed also a cortico-subcortical hypodensity lesion in the right frontal parietal region, so an acute ischemic infarction. The blood pressure was a little bit high, 16 to 9.5. So, Eloisa, it's a long presentation, so let's focus on what the patient has now. She's 43 years old. She's having a stroke right now, and she has active lupus. What are your main concerns right now?
Okay, thank you so much. It's very nice to participate in this very exciting discussion on cases. And I would like to start with an aphorism that I like very much for lupus. Lupus can do everything, but not everything is lupus. And this is particularly true for neuropsychiatric manifestations. In the case of this patient, the pathogenic mechanism of ischemia is mostly likely related to a thrombotic event. Therefore, the primary concern should be to identify the underlying causes of this stroke in order to determine the most appropriate treatment. And there are several possibilities to consider, including disease activity, vasculopathy, antiphospholipid syndrome, and source of embolism. The basis for active lupus is immunocomplex formation, deposition, and vasculitis with inflammatory infiltration. And the patient has active disease to support this possibility. The other possibility is vasculopathy without inflammatory infiltrate and with endothelial cell proliferation and consequent thrombosis due to lupus itself or other conditions such as glucocorticoid or comorbidities such as dyslipidemia and also hypertension. And I would like to call your attention that hypertension is the most prevalent risk factor for a stroke in the general population. It's also an important factor for lupus patients. And very relevant for lupus patients is to consider antiphospholipid syndrome, which may coexist with lupus in about 20 to 30% of the patients. And stroke is the most frequent presentation, or second most frequent presentation of thrombosis in antiphospholipid syndrome. Therefore, investigation of antiphospholipid antibodies is mandatory in these patients, even if previously negative. And also, I would like also to call your attention that if the antiphospholipid antibodies and lupus anticoagulants are negative in this patient at this time point, we have to repeat after 12 weeks, since what happens is that sometimes, but rarely, we have deposition of antibodies and the antibody becomes falsely negative. And lastly, it's essential to identify a possible source of embolism, such as a ligament endocarditis. I think I covered the most frequent causes, possibilities.
Thank you so much. And you pointed out that really what the issue was going on with this patient. And actually, when the results of this event came up, she had turned positive for lupus anticoagulant. IgG anticardiolipins antibodies were high in titer, and IgG anti-beta 2 glycoprotein antibodies also pretty high, moderate high, and the carotid ultrasound were normal. And she actually has a mild mitral valve thickening on the echocardiogram. No vegetations, but she actually had a thickening, and she was started on a senocumarole. So stroke is one of the possible events, and you highlighted all the important points of it, and it can happen in SLE. It is acute, focal thrombotic, but as you pointed out on your discussion, should we attribute this stroke to lupus or not? And we can do the exercise of the models of attribution for the NP events to SLE. We can use ANALYSE, the most stringent attribution model, and on the ANALYSE attribution model, this NP event would be attributable to lupus because it happened 1 year after the SLE diagnosis, so it's close to the diagnosis. It has antiphospholipid positivity, but there is no other comorbidity that was found. And this stroke is not a minor event of NPSLE. So if we use the attribution models, this event would be attributable to lupus, even so. And if we use the Italian algorithm, this event would also score 7 points. And 7 points is the cutoff of a positive prediction value of 83% for an event to be attributable to lupus. So actually the 7 points is the cutoff, and this patient she scores 6 points. So she is on the gray area for the attribution of this event, taking into account all the scoring systems. So, do we think that this APS that she's having, despite of lupus, is considered a comorbidity, or is it considered also a part of SLE? So, Murray, taking this into account, this discussion part, and whatever you want to discuss about this case and all what is surrounding, what do you think are the pros and cons of using the attribution models? And when they are on the gray area, how do you think it should be solved? Always with the expert opinion? What do you think?
So there are a number of issues here. First of all, let's talk about these classification criteria, or whatever you want to call them. In rheumatology, we have a lot of dealings with classification criteria, for disease diagnosis, and in this case, for classification as related to lupus or not related to lupus. Classification criteria are important when you're doing large studies with patients, and you want to make sure the patients you include in a study are all definitely the diagnosis that you're claiming them to be. So they must satisfy classification criteria. But look at the classification criteria in lupus, diagnosis of lupus itself. You have ACR have 2 classification criteria, the original one in 1997, and then you got the SLE criteria, and now recently you've had the EULAR ACR criteria. So you've got discordance among criteria here. So yes, we use criteria, but we tend to use them more for inclusion into large studies where we want homogeneous groups of patients. In the final analysis, at the bedside, number one, the doctor doesn't use classification criteria. They don't have them at their fingertips. Number two, sometimes the diagnosis of an individual patient overrides what the criteria would say. Okay, so I think CNS lupus is the best example where, yeah, there are criteria, but in the final analysis, the clinician at the bedside makes the diagnosis. Okay, so this woman, look, the woman gets lupus. 9 months later, she gets lupus nephritis. 1 month later, she gets a stroke. How could anyone say this was not all due to lupus? Right? I mean, this is all sequential, one happening right after another. You're in the gray area, the exact area, the not. This is lupus. Okay? And then the big controversy here is, were these criteria considering antiphospholipid a feature of lupus, or was this a comorbidity which is not due to lupus? Look, could this woman have lupus and then 9 months later lupus nephritis, and then 1 month later develop a whole new disease unrelated? It would be unusual. Okay, so I think this is lupus. If this is all lupus, what do I do about it? Well, you've started on the treatment. But with lupus nephritis, the significant type of lupus nephritis, class 4, you've started her on cyclophosphamide in addition to the steroids and the hydroxychloroquine, and you've made the beginning. Lupus nephritis won't have responded yet, and clearly the central nervous system lupus hasn't responded yet, so stay firm with the treatment. However, this woman does have a clotting feature here, right? Yes. And we see this, and we see it in kidney disease with thrombotic microangiopathy. You see it with CNS disease like you're seeing here. So what should we do more than we would do for treatment of lupus? And the answer is, I think this woman should be anticoagulated as well. So Stay strong with your treatment of lupus. Continue your cyclophosphamide course that you've started, but add in an anticoagulant, which they have done here. And so I'm glad they did that. And so the bottom line is, I think this is lupus. Classification criteria of interest for clinical studies, but at the bedside, the clinician makes the diagnosis.
Perfect. Eloisa, do you have anything to add?
Well, I agree. I think it's very difficult not to agree with Murray. Okay, because he's
dangerous
great.
even.
Okay, I'll talk a little quieter next time. Sorry.
But anyway, I think it's very important for this patient. We have to, lupus activity should be treated, but also hypertension. So it's something that's very important for prognosis during her disease. And I agree that this patient, it's very important to know if she has antiphospholipid antibodies, because these may change the way you treat the patients in a way that long-term anticoagulation will be recommended if she is positive. And if she was not positive, then perhaps we could think in a different way. And the second point I would add to this patient is the possibility of a source of embolism, because I think this is something that we always have to be very careful. Otherwise, we may miss it if you don't think about that.
Thank you so much. I think we might dive in the second case, and also on NPSLE. In 1988, a 28-year-old woman was diagnosed with lupus based on arthritis, skin rash, mouth ulcers, photosensitivity, anti-nuclear antibodies positive, double-stranded DNA positive, and anti-cardiolipin antibodies. 6 years later, when she was 34, she developed papillitis of both eyes with vision loss. Her MRI had no abnormalities, and she was treated with methylprednisolone bolus 500 milligrams for 5 days. She got better. 1 year later, she had a papillitis recurrency, and she had no bulbar or other involvement on the neuropsychiatric involvement. And at that time, lupus was considered to be the most likely cause of this papillitis. So she was treated with cyclophosphamide, 750 milligrams per kilo for 6 months, and prednisolone, 60 milligrams for 4 weeks, and then tapering to 10 milligrams, lowering every 4 weeks. After 6 months, she was completely improved. Perfect response to cyclophosphamide. But another 6 months later, she gradually developed over several weeks some problems urinating, sensory disturbances on the left thigh and right leg. And on the physical examination, this was confirmed. Hyposthesia in her left leg, feelings of different temperature in both legs compared to arms, and the MRI revealed an inflammatory myelitis from the cervical 6 to the thoracic 2, so 4 levels. This was in 1997, and she was treated again with cyclophosphamide and prednisolone. She did quite well for several years under treatment, and on the maintenance treatment, she was on azathioprine and cyclosporine because she also had skin and joint involvement from lupus. And then, when she was 52, in 2016, 19 years after the last myelitis flare, she developed hyposthesia of the thorax, and the MRI revealed a myelitis over a long span from thoracic 2 to thoracic 10, and she was still on cyclosporine. And at this time, a laboratory test was done to aquaporin 4 antibodies, and it was negative. Combination treatment with prednisolone and rituximab, followed by belimumab, was given, and she responded quite well. But after 2 years, she developed again less straightening in both legs, sensory disturbances in both legs, and specifically C9 and thoracic 7 dermatoma. So new miction problems also, and inability to defecate. Okay, now a little bit in quality of life, this was a little bit more severe. And the MRI revealed new lesions from thoracic 4 to thoracic 8, and a sharp reduction in the previous lesions that it was observed. And at this time, the aquaporin antibodies were now positive. So, based on the recurrency, rituximab maintenance therapy was given every half year. Then in 2020, she developed some recurrent infections. IgG was low, probably due to several rituximab maintenance treatment. And she is now on IVIG, and the infection problems disappeared. So, Murray, here we are seeing a patient with recurrent myelitis that have started with recurrent papillitis as the main clinical feature. This is not quite common in lupus. And now we know that she has neuromyelitis optica, so an NMO spectrum disease, and SLE. But at the time, in the 90s, it was difficult not to attribute these papillitis and myelitis to SLE. And do you think that with the current knowledge, what do you think that this patient had from the beginning? Do you think was this disease? Was lupus in some kind of activity? What is your experience through all these years with myelitis and lupus?
So this is actually a very interesting patient. It's clear that she started with lupus. That was way back, 1988, etc. And then she goes for a long time being relatively quiet on minimal therapy. Mm-hmm. And then 6 years later develops her first papillitis. And over the next, many years, 25 years, she has episodes of neuromyelitis optica spectrum disorder, right? So mainly myelitis then. So here you really have a classic example of an overlap syndrome. Or, in our first case, when he presented, I think back to that now, that woman with lupus in the first case started out having autoimmune thyroiditis. So autoimmune thyroid disease, autoimmune diseases do coexist, right? Yeah. So did she have lupus in the beginning and then she no longer has it, now has the neuromyelitis optica spectrum disorder? Or are they both there at the same time? That's very interesting because in the description, you were saying that she was, while she had developed one of these neurologic episodes, she was still on cyclosporin because she had ongoing low-grade lupus. So her lupus didn't go away.
Not
she did have low-grade lupus all this time, but the major manifestation was the neuromyelitis, NMO.
Okay.
So I think both diseases coexisted. It's almost like someone with lupus also having Sjogren's syndrome. We've seen that, with very dry eyes, positive anti-Ro, anti-La, but they have lupus. And so the two can coexist. And I think we do have a coexistence in this case because there's low-grade lupus in the background and very severe NMO in the foreground. All right, so that's an interesting discussion, but what impact does that have on therapy? And luckily, it'll have no impact here because with with NMO, you treat it vigorously and then you stop your therapy. And sometimes they're one episode or very few episodes. This woman is much more than that. She has recurrent episodes, which are severe. And so in the recurrent, you need more intensive anti-immunologic, anti-inflammatory therapy. And it has to be chronic in order to prevent these attacks. And that's the reason I think she was wisely being treated with rituximab. And when they had the rituximab side effect with the low immunoglobulins and infections, they treated that. monitored that, and they're monitoring her. So I think whether we call this two concurrent diseases or that it's now primarily one disease, the other disease is the background, I think the foreground disease requires chronic therapy, chronic immunologic therapy, which she is getting, and I think that is the appropriate approach for her. But it raises that whole question again of the concurrence of two autoimmune diseases, which we see very often in patients with lupus.
Eloisa, so I'm not an expert, so I'm learning with you. And as a non-expert physician, but I deal with lupus, I'm going to try to stick to the attribution models so I can be more certain. And if we do this to this patient, when the papillitis and the myelitis first presented, they would be attributable to lupus on both attribution models. And so luckily, they are treated the same. So as Mary was saying, but in your life, in your experience, do you have this experience that papillitis and myelitis, are they common? In lupus, how do you feel when you have a patient with this kind of presenting symptoms? How do you feel about it?
Okay, we have a large series of myelitis in lupus here because we are a tertiary center. And I have a view, when we see myelitis, you can have two distinct patterns. One pattern is predominant gray matter involvement with flaccidity, hyperreflexia, and is characterized by acute episodes, few hours, and usually non-reversible, non-recurrent, and highly associated with disease activity, anti-dsDNA, low complement. And so in this case, it's easier to attribute to lupus because it's associated with disease activity, so it's easier for us. On the other side, we have a predominant white matter pattern with spasticity and hyperreflexia, characterized by indolent progression. It's the case we saw here, and frequent relapses. Optic neuritis is very common in this spectrum, and this patient usually fulfill neuromyelitis optica spectrum syndrome. And interesting, these are the patients that have aquaporin 4. They also have antiphospholipid and anti-Bo antibody. But this patient we are discussing here fulfills the second pattern. And this pattern is much more difficult to attribute to lupus because you have to think in other disease. And I favor that these are the two diseases that coexist. And in favor in reinforcing this possibility, it has been demonstrated that connected to disease patients that have aquaporin 4, they all have they have neuromyelitis spectrum syndrome. And lupus patients with other neurological manifestation or without neurological manifestation, they do not have aquaporin 4. So my feeling is that we have two diseases that have the same underlying genetic predisposition. So for one, the attribution is very easy, and for the other, you have to raise a red flag and say, is this attributed to lupus or not? And in this case, I think it's another disease, and as Maureen said, luckily, it's the same treatment. Otherwise, would have damage for these patients.
Okay, thank you. Mary, do you want to have any thought on this case?
No, I guess I agree with everything Eloisa said. And again, it puts the clinician in the forefront here. We can argue is it two diseases or concurrent disease or the same disease, but the clinician made the decision that this patient requires chronic immunosuppressive therapy.
Yes.
And that was the right decision, whatever the classification was in the beginning.
Thank you. I think we can move to the third case. And the third case is a 24-year-old woman that she was diagnosed with SLE. And this was in December 2013, based on malar rash, photosensitivity, diffuse alopecia, oral ulcers, and bilateral pleurisy. And she had class 4 nephritis on the presentation with positive double-strand DNA, low C3 complement, positive lupus anticoagulant, negative anti-cardiolipin antibody, and negative anti-beta 2 GP1 antibodies, both IgG and IgM. She had no thrombotic or obstetrical history. For the lupus nephritis and all the rest of the systemic lupus, she was treated with pulses of methylpred, 1 gram each, and followed by prednisolone, 0.5 milligram kilo per day, MMF, 2 grams a day, and ACE inhibitors. Steroids were tapered when she had 6 months of treatment. She had only 5 milligrams a day, and the daily proteinuria decreased and was under detection for 0.5 when she had 6 months of follow-up for the lupus nephritis. The complement C3 returned to normal. Steroids were stopped 2 years after the lupus nephritis, and she was on hydrocortisone 20 milligrams a day that the physician that was treating her preferred instead of prednisolone. Then the MMF were decreased because she was so good to 1 gram a day in September 2015. So more or less 2 years after the induction of the lupus nephritis. And 6.5 years later, on January 2022, she was 31. She was on prednisolone 5 milligrams a day, MMF 1 gram a day, and she was hospitalized because she had altered sleep-wake cycles, hyperactivity, intense anxiety, ideas of persecution and auditory hallucinations. She had no arthritis, no mucocutaneous manifestation, physical exam were normal, neurological exam were normal, and the lab test, the laboratory tests showed normal C3 fraction, and the anti-double-strand DNA was not negative, but it was slightly elevated, not as high as in the beginning, but slightly elevated. And the psychiatrist that saw her made a diagnosis of acute psychosis. The CSF was normal, the MRI was normal, and the physician that was treating her also asked for anti-ribosomal P, and we don't know the results yet. So, Eloisa, thinking of this, what is your feeling about this psychotic event?
First, it's a difficult question. I do not think there is a specific feature favoring or not favoring the lupus attribution in this case. Atypical psychiatric symptoms, for example, visual, tactile, olfactory hallucinations, particularly if they come together, suggest an organic involvement. Also, if the patient has disease activity, this also highly suggests that this is organic involvement. And attribution will be easier. In this case, she has auditory hallucinations, which are also frequent in primary psychosis. And she does not have disease activity established. So it's not a very easy attribution, but the Italian attribution algorithm might be helpful guide. And I wrote down a few things. We have 2 points for more than 6 months of disease. We have 3 for not being a minor event. This patient was hospitalized. 2 for no confounding factor. She does not have a marked psychosocial stress or use high doses glucocorticoid. And 0 for no additional favoring factor. Like we don't have the data, but she doesn't have an TP, she doesn't have abnormal neuroimaging, and no familiar history. So the count would come to 7, which has a high specificity greater than 80, and this would be helpful. But the physician has to decide And I would like to emphasize that a lupus patient with a new manifestations, we must exclude other causes, such as infection, like, for example, herpes. We have to have CSF that she had, that was normal. But even if CRP is low, you have to look for infection in this patient, MRI for other organic causes. And we also have to check for the use of illicit yes. drug and drug side effects. And one point that I would like to call your attention also is that seizures, frontal seizures, also are associated with psychosis. So it's important to have a electroencephalogram in these patients. Thank you.
Thank you so much. Murray, what is your feeling about this event, this psychotic event in this patient?
So the first thing I want to say is hurrah for the patient, for the doctor, not the classification criteria. I don't believe that I would diagnose lupus central nervous system disease on this patient. She has been in remission for 7 years with nothing else, on minimal therapy and really very unimpressive laboratory values. We don't know the anti-RMP or other antibodies, but anyway, everything else is negative. I think this is a primary psychosis and should be treated by the psychiatrist with close follow-up by the rheumatologist. And, you know, being able to get a 7 in the ANOLA criteria saying that this is definitely due to lupus is really troublesome for me, because that would lead me to treat her. And I would not, you know, to treat this woman now means large doses of steroid.
Yes.
And maybe other immunosuppressive drugs. There's no indication for me to do that. So close observation, psychiatric therapy, and follow her carefully.
And if the patient had antiribosome, high titer of antiribosome P antibodies?
Eloisa, I still at the bedside would like to watch her. You know, it's because the commitment here would be huge amounts of steroid and more. And that has, you know, in a woman who's already psychotic, that has a real significance. Now, I mean, things could evolve, you know, over the next number of months. We don't know the long-term follow-up. And she could develop other signs, etc., and she could have multiple antibodies. Then we might change our mind. But as presented now, I would say she should be treated by the psychiatrist with close follow-up by the rheumatologist.
We know that the physicians started on steroids and she got better, which is in favor of being related to inflammation. But only after responding is that we know that it responded to steroids. And if it was a psychotic psychiatric disease coming, it would probably worsen. So before we had not much clues to treat this as a psychotic NP event of SLE. And the thing I really like to highlight and ask your opinion on this is we only did MRI. The attending physicians only did MRI from the neuroimaging. And probably this is the case of patients that we will need functional imaging to see if there is metabolic changes there, because not every NP event has changes on the MRI, even with contrast. So functional metabolic MRI would be a very good tool when it's validated to approach this patient. Because if we knew that she was having activity, metabolic activity, probably we would think again on doing immunosuppression, not with such fear as seeing this patient at the bedside. So this was really a difficult case. Thank you so much for your highlights. And now the last case, which I'm curious of your opinion. And this is a patient with 38-year-old, and she presented on her follow-up consultation for systemic lupus. She's on 5 milligrams a day of prednisolone and hydroxychloroquine 400 milligrams a day. She's having headaches for 1 month. On physical examination, she's completely normal. Her neurological examination is normal. No respiratory, cardiovascular, joint, or skin examinations are different. And I can add that all the labs for the monitoring of activity are normal. Murray, do you think this headache is attributable to lupus? Do you think it could be? And if not, what do you think are the risks of not treating this?
So I'm actually happy to be able to deal with this because I've had many accusations in the past about attributing headaches to lupus because of the SLE day. SLE day included headache. But then people just read the left-hand side of the slide of the table and not the right-hand side. The right-hand side said headache has to be severe, persistent, and non-responsive to narcotic medication. So we're talking about a different kind of headache. There are headaches that are very identifiable. In central nervous system, vasculitis, you have a thunderclap headache. Everybody knows what that is. And in lupus, for the SLE day, if you follow the definition, it has a very specific headache. I don't think this woman qualifies for that kind of headache. It's only a month. It's dragged on. There's no sign of having to use narcotic medication. So I would like to just investigate her and treat her as a headache who comes to a general medical clinic and follow her rather than committing myself to lupus. Now, Raquel, you make a wonderful point before. If we could all get functional MRIs or PET scans on all of our patients and look at the metabolic abnormalities that are occurring, this would be a good one to apply that to, to see, does she have any metabolic abnormalities? We could certainly do that. For many of us, that's not an easy assay or test to get quickly. So in this case, I would say this is likely not lupus, and I would follow her carefully.
Thank you so much. Eloisa, do you have any thoughts on these? Do you want to have any thoughts on NP events in SLE in a global way?
Okay. Now, on this case, I agree. I would like to make a statement that the causes of headache in lupus are similar to general population. It's very important to know that we have mostly migraine and tension headaches. So this said, I think in this case with clinical and neurological examination is normal, no red flags. I agree that this patient we can observe and treat her with standard therapy for headache. And I agree, if this headache is severe, then we have to investigate in the patient, particularly if the patient, for example, has antiphospholipid antibodies. This will make us look for. And also we can think of in the Italian algorithm in which they give some lights that we have to investigate other causes for headaches. They call cranioneuropathy, associated disease of eye, ear, sinus, spine, cervical spine. So we have to remember that lupus can cause everything, but not everything is lupus. I think it's very important when we are dealing with psychiatric manifestation in lupus.
Thank you so much. I will ask you, Marie, to comment on one thing. We are really worried about knowing if the NP events are related to lupus or not and how to treat them. But when it comes to minor NP events, as headache, as we discussed, anxiety, mood disorders, they are quite common on the global population, but they are quite common in lupus also. And even if it's not due to lupus, it highly affects quality of life in our patients. And Marie, please comment on this. with your huge experience.
You're absolutely correct, and it's a dilemma that we have in our patients. Even in general lupus now, we've got type 1 and type 2, where type 2 has nothing to do with active inflammation lupus, right? So we do have a lot of things that happen in lupus that aren't related to lupus, but definitely affect the quality of life, etc. So, when you come to a thing like headache, even though it seems like a routine headache, there is that possibility it's related. And when the investigative mechanisms become more easily available and more definitive, we'll be able to use them, hopefully, and help us decide whether these common population-related manifestations are lupus-related or not in this case. So what I tend to do is I look at the patient and the other features. What is the antibody status? Are there other features of lupus at the same time? Could I make this a general flare of lupus? If nothing else is available and there's no obvious investigative mechanism that can help me, I just follow the patient and treat them as I would treat headache in the general population, but not treat them as lupus, because central nervous system lupus requires large amounts of treatment.
Yes. Eloisa, Murray, thank you so much for joining me today and sharing your insights. To our listeners, we hope these discussions have helped you gain more of an understanding of lupus. Do send us feedback on cases you would like us to discuss in the future. Thank you so much for listening. We hope you enjoyed this podcast. Please leave us a review, which will really help us in reaching as many of your colleagues as possible around the world. Join us again next time.